Thank you, Amy, for that lovely introduction. For the delegates, if you have any questions throughout this session, please could you put the questions in your discussion tab, and I'm quite happy to answer them at the end of the Q&A. So today's session, I'm going to talk about learning disability awareness and a case study. So if we just go back to the very beginning, and talk about a definition of learning disability and what learning disability is. So what we know is Value and People in 2001 developed a definition, and it talks about including the presence of a significant reduced ability to understand new or complex information or to learn new skills. And it's also about a reduction in ability to cope independently. An impairment that starts before adulthood and will last over somebody's development of their life. And MenCap also added to that, which is important, in 2002, and they talk about a learning disability that's a lifelong condition acquired before, during, or soon after birth and affects somebody's inability to learn. When we talk about learning disabilities, we talk about that there's on average 2% of the population who has a learning disability. In the old terminologies, we refer to IQ testing, and anyone whose IQ was below 70, so you might see that in the older population, that their IQ is below 70 and they would fit under the umbrella of somebody with a learning disabilities. The IQ goes lower when we talk about mild, moderate, severe, and profound. That information is, we wouldn't use that as a clear definition of a learning disability today. When we talk about learning disability and learning difficulty, these two words are intertwined quite a lot. When somebody is described as having a learning difficulty, it's a very specific individual difficulty. So we talk about dyslexia, dyspraxia. So it's one specific difficulty that somebody might have in learning. Whereas we talk about somebody with a learning disability, we talk about somebody having a global, so that's having an impact on every part of their life. So it might be about finance, about living independently. So it impacts them globally, really. What I want to do is talk a bit about the documentation that we have in front of us today. This documentation is a number of reports that have been developed over the years, starting off with Value and People. And Value and People was looked at people coming out of institutions and also about people with learning disabilities having a GP and ensuring that their health needs were being met. We move forward, and the next document we talk about death by indifference. And MenCap wrote that paper with the support of 6 individuals, their families. And it was very much about individuals who died prematurely and of preventable deaths. A very, very difficult read. But the families talk about the challenges that were faced with their loved ones. If we move 2 paces on and we see a mum and a daughter, 2 years later, MenCap wrote another paper, and it's called Death by Indifference plus 74. What we've learned from the very first Death by Indifference was actually we didn't learn much. We had 74 further deaths of people dying of preventable causes who had a learning disability. This was shocking and outstanding for the learning disability population. So if we go down to the bottom line of documents, we'll see one with leaves on it, and it's called the Confidential Inquiry. And from that report, it highlighted the needs that we need to change, that we need to look at how we support people who have health needs comorbidities, and also how do we support people in acute hospitals. And that was the beginning of having learning disability nurses in an acute hospital, which is what I am employed to do currently. If we go to the very end report, it talks about treat me well. MenCap again wrote this document, and this is about how people with learning disabilities want to be treated, how they want to be treated the same as anyone else. Just because they have a label, learning disability, it doesn't mean that they need or want to be treated any differently. So we have some shocking headlines. These headlines are really, really difficult to read and to take on board. But I'm sure that you've seen headlines within TV or local papers about the impact of somebody who has died, who has a learning disabilities, and the impact that has had on the family. What we have back in 2013, a young man called Connor Sparrowhawk. He is known as the Laughing Boy. So if you look him up, his family will talk about him and always happy and joyful. And he went into a psychiatric hospital, had a bath, had epilepsy, and died following a seizure. And Oliver McGowan is a young man who was 18 who died in a Bristol hospital in 2016. His mum Paula has gone to Parliament to make changes to empower people with learning disabilities and autism to have the same rights as us. And she has also supported a training, an Oliver McGowan training for social services and NHS staff, which I'll talk about later. So we talk about healthcare and the experience of healthcare of people with learning disabilities. They describe it as frightening, confusing, stressful. These are all really harsh words and difficult words that we take on board. And we ask, we kind of look at that and we've identified that people with learning disabilities might find it more difficult to communicate. They might find it more difficult to express themselves if they're in pain. And also the psychological part of that. If somebody from their family or close friends have come into hospital and never returned, so they might have died, actually the fear of the word hospital might be that they're worried that they might return back to their own home. So we need to consider the impact this has on individuals with a learning disability. So I will talk about statistics and information and evidence-based practice. This is from what we call the LEADER programme. So the LEADER programme was identified in 2016 following the number of deaths that people with learning disabilities had that were preventable. So there's been reports since 2016, as you can see, these can all be downloaded from the internet. So the latest report is from 2022, and this has been written by King's College London, and they have looked at the national deaths of people with learning disabilities. What we have gathered from this is that 42% of the latest report identifies that avoidable deaths for people with learning disabilities. This has been reduced from 50 back in 2021, so there is improvement. But if we do a comparison to the general population, that is 22%. So there's still a significant discrepancy really within that. If we look over to the next one, what we have is the top 5 deaths of people with learning disabilities. For the purpose of this presentation, if we look at cancer, that's 14.6% of deaths of cancer. I can't break that information down, but if we talk about the top 3 avoidable deaths, if we look down to the next one, we talk about cancers, and again, from that figure, it's 15.7 of avoidable deaths. So if we consider the cancers, prostate cancer, that will fit into that. And how are we supporting individuals with the learning disabilities to be screened or supported to have their assessments or treatments? On the final slide, we can look at cancers, and it's divided into kind of three sections. From previous 2018-2019, it talked about 26.3% of the population had a prostate cancer diagnosis. If we go over to 2022, that's changed to 7.2. What we know is the general population is 7%. So again, that's on par with the general population, the learning disability population. If we look at just specifically people with autism, so they don't have a learning disability, a very cohort study was completed recently. And if we look at cancers, again, frequent cancers of people with autism. If we go to the next one, it's 81% of autistic adults who died in 2022 were male. So again, about how do we support this population to have their assessments or support them within reasonable adjustments to come into GP surgeries or hospitals to have their assessments or treatments. I want to kind of share with you some health inequalities. Going back to the reports that have been written recently and previously, just because somebody has a learning disabilities, they say I'm 4 times as likely to die from a preventable cause because I have a learning disability. Just because I'm a woman, I'm likely to die 27 years earlier, just because I have a learning disability. And likewise, I'm likely to die 23 years earlier if I'm a man and I have a learning disabilities. They're quite shocking. They're quite kind of thought-provoking statistics. We need to change that. We do that by the LEADER programme, by looking at the deaths and how we support what we need to do to change, but also by yourself saying, how do I make a difference to this population who are vulnerable, who may have challenging communication needs, but we need to support. So some of the barriers that we might see within the healthcare system, and how do we kind of overcome them? So we've already talked about communication difficulties, complex behaviour, health needs, and that fear, the anxiety of somebody. We need to consider how we support that individual. Accessible information. We need to have easy read information for those individuals. Also, organisational. So what we have is quite rigid appointments. Come in at 9 o'clock. We could be sitting in a waiting room. That might be hugely difficult for individuals who haven't got an understanding of time, how long it will be, waiting to see somebody, the fear of the hospital. So all of those included. And what we have is we can use the Equality Act of 2010, and that Equality Act, within it, it talks about reasonable adjustments. And within that reasonable adjustments, it's about, can we change the time to suit that individual to come into the hospital? What can we do to enable and to empower that person to come into either GP surgery, either health centres, to have their assessment or treatment? To remove some of those fears and anxieties. Reasonable adjustments come into all shapes and sizes, and I'll talk about those in a little while. Also, professional barriers. We need to consider how we as professionals, how can we support, what language you use, how do we make it, how do we empower people with learning disabilities to understand medical terminology. Diagnostic overshadowing, I will explain in a little while. So if we consider some of the common health challenges that somebody with a learning disability might have, there's a number up here, but if we also consider there might be some comorbidities. So a person with learning disabilities, we know, will have more than one health need. So if we consider somebody with Down syndrome might have a mental health difficulty. What we're saying is 54% of people with learning disabilities will have a mental health condition. So if they have that, and also then they might develop dementia. So if somebody with Down syndrome develops dementia, then that might look at somebody having respiratory difficulties, dysphagia. So as you can see, somebody will have a number of, so they will have a whole host of comorbidities, which again makes it more challenging to support somebody with a range of health needs. Diagnostic overshadowing. We talk about this within the learning disability population quite often. So it's very much about people's physical symptoms are blamed on their behaviour because they have a learning disability, rather than actually investigating their health needs. So it's been known and quite a lot written that a person with learning disabilities will go to a health professional and they will say, oh, that's because you've Down syndrome, that's because you've got Fragile X, that's part of the condition. Well, actually, we need to do better. We need to not blame the learning disability and actually do some deep dive into that person's health need. When we are prescribing for somebody with a learning disabilities, just for consideration, we would prescribe within the elderly population. There might be sensitivity, there might be concerns with somebody starting new medication, they might be on a multiple medication, and that's what we would look at. This is a really good, easy read guide that you can download, and it breaks the information in an easy read format for a whole host of medications, and that we will print off and give that to the individual to help them to understand their medication, what's been asked, why they're taking it, and breaking it into an easy read, which will have pictures and easier language. So from my role, what I want to share with you is what my role as a learning disability liaison nurse might be in the hospital. We have increased staff awareness, so supporting individuals and families to come into hospital. We look at what reasonable adjustments we need to do and how we can support within the hospital. We've already spoken about reasonable adjustment, but it comes, as I said, an array of types. So we might have extended appointments, flexible appointments. We might have that we support somebody to come in a bit later rather than coming in at a very prescribed hour for if they were being admitted to a hospital under planned care. Within MenCap Liverpool, these individuals have shared with us some of their stories, and it's about them as individuals. Don't be looking at my wheelchair. Help me to understand the language that you're talking about. Break it down. Don't assume I know something. Communication. What we know is 75% of people with learning disability have communication difficulties. That's a lot, and it's our duty under a reasonable adjustment to support them to understand. We also know about 20% of people have no verbal communication, and it's about how we support. Communication, there's lots and lots of ways, and I suppose if you have community learning disabilities teams, or if you're in a hospital, have liaison nurses like myself to support with communication along with our speech and language therapist colleagues. There's leaflets, there's easy read, huge array of information on the internet that we can support. When we talk about capacity, I'm not going to go into detail about it, but what we need to do and remember is that don't assume somebody lacks capacity just because they have a learning disability. Just go through the assessment when we assess somebody with a capacity for mental capacity to understand, do they have the capacity to take on board this information, and have we done our job to help them understand it in a format that they understand. When we talk about capacity, we need to also consider, as we said, presumption of capacity, but supporting the decision, even if they understand, is it an unwise decision? People are allowed to make unwise decision. Is it in the best interest for that person if we deem them to lack capacity? And also least restrictive options, that's important. So I always say, if staff ask me, what would I do if a patient didn't have a learning disability? How would I treat them? What treatment plan would I have? What care plan? And what's the least restrictive? And we would do the same for somebody with a learning disability. So I want to quickly go through a case study with you. This gentleman is called Albert. Albert came into the hospital. It isn't specifically about prostate cancer, but what it is about how we supported and made reasonable adjustments, which I think is very powerful in enabling Albert to have his assessments and treatment. So Albert is a 68-year-old man. He lived in institutional care as a young man, and he's very complex. Behaviours of concern, he's non-verbal, severe learning disabilities. He can be aggressive. He hates hospitals and medical intervention. He lacks capacity to understand anything about his own health, but he loves Cokes and Mars bars. So I received an email from the community learning disability nurse in the community saying that the GP was concerned that Albert had testicular cancer and wanted to come into a ED. Our emergency department is just chaotic. It's a very busy environment, and with knowing who Albert is, did we feel that was in his best interest to come into hospital? So what reasonable adjustments did we come up with? So I contacted the department, urology, and asked them, could we make reasonable adjustments? It was agreed that he'd come into the next available clinic. He would have an ultrasound. He would be supported by his support workers and members of the community learning disabilities team. And he's also prescribed under a care plan to have 5 milligrams of diazepam if he ever comes into hospital. And that was so effective. What we had was what reasonable adjustments was needed when he actually came into the hospital. No waiting rooms, no waiting around, no loud noises, because that would cause him concern. Don't sit beside anyone in a waiting room, not to use difficult language to him when we're speaking to him. Tell him he's not going to stay in hospital, because that was important, and that might have to be a planned admission, but on this day he was going home. And also top tips what he likes, so we could then empower the nurse who was seeing him what was important. How, what, where, and when. We put all the plans in place, and we also got the sonographer to be on standby on the day of his appointment, because that was how we could move forward. Everything was planned for him. On the day, we had a phone call to say that he left the house. He was given his 5 milligrams of diazepam. Not told he was coming into hospital, because that was important to him and in his best interest. I met him on arrival, and when I met him, we then phoned the outpatients clinic where he was going. He came straight into the clinical room, and we spoke about Mars bars and Coke, because we knew that would help him, calm him. That was important to him. Everything was calm. Paperwork and discussions were complete by the clinical team. He was in a wheelchair. He wouldn't lie in the bed. He had massive mobility issues. And again, with the diazepam, so he was quite unstable. So again, the reasonable adjustment was to stand up, to support him and to have the clinical team to have a quick visual look at the area, really. And what that was agreed, he needed a consultation with the consultant for his opinion on the way forward. We needed an ultrasound. So we moved forward. What we were able to do was support Albert to have his ultrasound. We bargained with them to lie on the bed. We were going to make his sore, so the area that was sore, better. And that's how we spoke to him. We had to put a hands-on approach, so we supported him to lie on the bed. He wasn't happy, but it was the least restrictive. It was in his best interest, and we all felt that we could do this and it would only last minutes, which it did. We had a discussion with the consultant, the consultant was able to diagnose abnormal left hemiscrotum, so he had a hernia. The consultant then was able to, well, he attempted to reduce the hernia, but Albert screamed, it popped out. So what was agreed, rather than causing any more concern, anything more difficult for Albert, it was a referral to a surgeon. So a few weeks later, we revisited the same care plan. We had the same discussion. We were able to bring him into the outpatients clinic again. He knew from his last visit that he was coming home. We had an IMCA, which is an independent mental capacity advocate, and they were able to have a discussion outside with Albert in his home environment with his staff, and also came in to the hospital. What we identified was that he wasn't a candidate for surgery due to a number of his health comorbidities. We developed a plan for the staff, who were support workers, for early warning signs if anything were changed, and we made the GP aware. And Albert went home successfully and remains at home, has no issues, but what we have been able to look at all the issues related to Albert. So that's finishing my presentation today. I hope you found it useful, and we can go on to questions now.